Okay, let's go ahead and get started. Welcome. We are so pleased that you all joined us this afternoon for a Division of Nutrition, Physical Activity, and Obesity seminar series that focuses on community actions to improve breastfeeding rates. CDC's Division of Nutrition, Physical Activity, and Obesity, DNPAO. Our seminar series showcases the science and practice of our work. Oops, sorry, my screen just shifted. And the seminar series is intended for partners, for practitioners in the field, for everyone to kind of get a better sense of what's going on and opportunities in the future. I'm Janelle Gunn. I serve as Associate Director for Policy, Partnerships, and Communication in CDC's Division of Nutrition, Physical Activity, and Obesity, and I'll be your moderator today. Today's seminar will highlight community actions to improve breastfeeding rates. Increasing breastfeeding rates and supporting optimal breastfeeding practices is a priority for DNPAO. We've seen improvements in breastfeeding initiation. About 84% of infants in 2018 have received breast milk at some point, but there's still work to be done. Most infants are not exclusively breastfeeding or continuing to breastfeed as long as recommended. Only 26% of infants are breastfeeding exclusively at 6 months as recommended. Breastfeeding initiation rates vary geographically with large racial ethnic disparities nationally and at state and territorial levels. Focusing on communities with lower breastfeeding rates can reduce disparities and improve infant nutrition and health. So we have some really wonderful panelists today. I think you all will really enjoy today's presentation. They'll describe their work to support community breastfeeding at the community level. Just a few quick housekeeping reminders for our time today. This Zoom seminar call is being recorded. So if you're not comfortable with being on a recorded call, we ask that you disconnect at this time. To have the best experience, we encourage you to use the Zoom webinar app to view slides and to participate in today's meeting. All participants will be muted. Following our three presentations, we will have a question and answer session. So the Q&A box is open at any time throughout the talk today. If you have a question, go ahead and load it into the box. We'll do our best to get to as many questions as we can with the time that we have. I am super excited about our panelists today, so I want to do a quick introduction of all of them to you. So our first is one of DNPAO's own, Jasmine Nakayama. She's an Epidemic Intelligence Officer, or what we call it CDC and EIS officer in CDC's National Center for Chronic Disease Prevention and Health Promotion in DNPAO. In her role on the Maternal, Infant, and Toddler Nutrition team, Jasmine leads CDC's first analysis of county-level breastfeeding rates. She received her PhD in nursing from Emory University's Neil Hodgson Woodruff School of Nursing and has a clinical experience in inpatient, outpatient, and emergency care settings and research experience using large electronic health record data sets. Harumi Reis-Reilly is a public health professional, nutritionist, and international board-certified lactation consultant. She is a lead program analyst at the National Association of County and City Health Officials, or NACCHO, and where she oversees the Reducing Breastfeeding Disparities Through County Continuity of Care project. This project aims to improve public health breastfeeding systems. Next, we have a team of presenters. So Cindy Young is co-founder of the Asian American and Native Hawaiian Pacific Islander Lactation Collaborative of California and the Asian Pacific Islander Breastfeeding Task Force. She is a program manager with Breastfeed LA, an organization dedicated to improving the health and well-being of infants and families through education, outreach, and advocacy. And her co-presenter is Tonya Lang, also a co-founder of the Asian American and Native Hawaiian Pacific Islander Lactation Collaborative of California, and a member of the steering committee of the Alameda County Breastfeeding Coalition. She is an international board certified lactation consultant, a certified health education specialist, and has supported chest breastfeeding and human milk feeding families for about 16 years. So first, for our agenda today, Dr. Nakayama will discuss why breastfeeding is important, how CDC monitors breastfeeding rates, new efforts to monitor county-level breastfeeding initiation rates using birth certificate data, and uses for county-level breastfeeding data. Harumi will discuss the recently released Continuity of Care and Breastfeeding Support Blueprint for Communities focusing on specific recommendations, strategies, and examples for communities to strengthen local infant feeding data. And then our final presenters, Cindy and Tonya, will discuss the diversity within the Asian American, Native Hawaiian, and Pacific Islander communities, review current breastfeeding and breastfeeding data and their limitations, and share current efforts to include and promote AANHPI voices in lactation. So without further ado, I would love to hand it over to my colleague, Dr. Nakayama. Jasmine?
Thank you. Good afternoon. I'm excited to see everyone here. It looks like there's a very lively audience. I can see everyone in the chat chiming in, so thank you. This presentation will review why breastfeeding is important. It will also summarize how CDC monitors breastfeeding rates, share new efforts to monitor local level breastfeeding initiation rates, and discuss uses of these local data. I want to provide a quick reminder of the importance of this work. Breastfeeding is the optimal nutrition for most infants and protects against many illnesses and infections, such as asthma and ear infections. In addition to promoting bonding between mother and infant, breastfeeding also provides health benefits for the mother, including decreased risk for some chronic diseases, such as high blood pressure and type 2 diabetes. One of our data sources for national breastfeeding surveillance is the National Immunization Survey, or NIS. NIS are the data that CDC reports on our website every August, on the breastfeeding report card, and for healthy people indicators. NIS is an annual nationally representative survey that is conducted by CDC using random digit dialing. Its primary objective is to assess vaccine coverage among children, and since 2001, questions on breastfeeding have been asked to caregivers of children aged 19 to 35 months to assess breastfeeding rates at national and state levels by birth year. The responses to these questions allow us to track breastfeeding initiation, breastfeeding duration, formula supplementation, and exclusive breastfeeding. Next, I want to describe another breastfeeding surveillance system that our team has recently started using, which is birth certificate data. The National Center for Health Statistics National Vital Statistics System is the federal compilation of birth certificate data, which are collected between the time of delivery of an infant and the time of discharge from the facility, or for infants that had home births, the time of the completion of the birth certificate form. The U.S. Standard Certificate of Live Birth collects data on many variables. One of the questions asks whether an infant is being breastfed at discharge, which is defined as receiving any breast milk or colostrum during the period between delivery and discharge from the birth facility, or completion of the birth certificate form for home births. Our team has used birth certificate data for a couple different analyses. A publication in May 2021 reported on racial and ethnic disparities in breastfeeding initiation using 2019 birth certificate data. The figure on this slide shows the largest disparity in breastfeeding initiation between maternal, racial, and ethnic groups by percentage point differences in 48 states and in the District of Columbia. The magnitude of disparity varied across the nation. These data also indicated that the specific racial and ethnic group with the highest and lowest rates varied between states. That analysis also indicated that states with higher breastfeeding initiation rates have the lowest disparity between racial and ethnic groups. Here, the light blue bars show the overall breastfeeding initiation rates within a state, and the dark blue bars show the disparity within the state, which is defined here as the difference in breastfeeding initiation rates between ethnic and racial groups with the highest and lowest rates. For example, Oregon is the first state on the left. Oregon has the highest breastfeeding rate and low disparity. West Virginia on the far right has the lowest breastfeeding rate and higher disparity. Another publication in June 2019 described the receipt of breast milk by gestational age in the United States using 2017 birth certificate data. This was one of the first times that we were able to look at breastfeeding initiation by gestational age, and we were able to focus on some of our nation's most vulnerable infants. This report indicated that the prevalence of infants receiving any breast milk was 48% overall, and this number varied by gestational age. Disparities in receipt of breast milk by several sociodemographic factors, including maternal race, and ethnicity were noted across gestational age groups. This slide highlights differences between NIS, which are the data that we release every year on our website, and the breastfeeding report card, and birth certificate data when looking at breastfeeding rates. NIS on the left provides data on breastfeeding initiation, duration, and exclusivity, whereas birth certificate data on the right only include breastfeeding initiation data. The most recent NIS data are for births occurring in 2018, whereas the most recent birth certificate data are for 2020 births. NIS provides data at the national and state level, whereas birth certificate data have data at the county level. Birth certificate data do not include California. California did not report this variable to CDC, and birth certificate data also do not include Michigan, which asked the question a little differently and resulted in data that were not comparable. Breastfeeding initiation data for California and Michigan will be available for 2021 data. And finally, birth certificate data can allow analyses for gestational age and disparities due to the larger sample size within this data set. This slide shows you a resource for county breastfeeding initiation data. This was recently published on our website last fall. The link is on the slide. The darkest blue on this map indicates the category of lowest breastfeeding initiation rates, and the lightest blue indicates the category of the highest breastfeeding initiation rates. The hashed lines indicate states or territories where data were not available, and gray areas indicate data that were not shown for confidentiality reasons. Overall, birth certificate breastfeeding initiation rates ranged from 22% to 100% across 3,001 counties and county equivalents in 48 states in the District of Columbia. We also presented rates for the territories of Guam and the Commonwealth of the Northern Mariana Islands, and for 78 county equivalents in Puerto Rico. These rates demonstrate wide variation within states and across the nation. You can also select a state or territory to get more detailed information. This is an example of the map and the first few rows of a table presented for a state. The breastfeeding initiation rate is presented for the state overall and for each county in a table. These tables of breastfeeding initiation rates by counties are available for download as a CSV file. You can also sort the table here by location name, number of infants, or breastfeeding initiation rate. Note that data for some counties are not shown, or the actual rate is not displayed to prevent identification of individuals. These data can be used by many people and organizations to identify local rates of breastfeeding initiation, to reveal disparities by location, to inform programmatic efforts, and to tailor local interventions more effectively. This concludes my presentation. Next, I'll pass it over to Harumi Reis-Reilly.
Thank you, Jasmine, and thanks for having me here to share a bit about the blueprint and what it says about local level breastfeeding data. So here are my acknowledgements. The Blueprint project is funded by CDC, DNPAO, so thank you. But the views within the Blueprint does not necessarily represent those of CDC. I also want to acknowledge that the content of in the Blueprint is a result of at least 100 professionals in the field. Here's a bit about us. NACCHO is the National Association of County and City Health Officials. Within NACCHO, the chest breastfeeding program falls under the Maternal Child and Adolescent Health portfolio and exists since 2014. We have tons of resources developed through this past 8 years, and most recently, we launched the Continuity of Care and Breastfeeding Support Blueprint that I'll talk about today. I also wanted to add a plug here for the NACCHO's Public Health Informatics team. I'm going to talk about gaps on local level breastfeeding data, but through their work, I understand these gaps exist across many local public health programs. So local professionals rely on data systems to assess community health, identify population needs, and create effective policy and programs. And although most data collection happens at the local level, this data is not easily accessible by local agencies. Usually the health data is fed from local to state to federal level. So NACCHO Informatics work to identify solutions within local health IT infrastructure to ensure that the data is collected and can be disseminated at the local level by looking at interoperability of systems and security of data sharing. So next slide, you see a snapshot of the blueprint. The blueprint goal is to ensure that lactation services are accessible, coordinated, and that all community spaces are consistently supportive. The blueprint was developed in partnership with the U.S. Breastfeeding Committee and their continuity of care constellation. The blueprint includes 7 recommendations divided in 2 themes: improvements in community infrastructure and capacity building of the local lactation workforce. The blueprint focused only on actions that can be taken at the local level. We launched the blueprint last August, and you can download the blueprint from the Continuity of Care Resource Repository website, and you see the link there in the slide. And next slide, you see the blueprint recommendations. Today, we'll focus only on recommendation 1 and 4 because they are the specific ones that discuss local breastfeeding data. And the rationale for those recommendations is that community data can tell the story of where continuity of care gaps exist and equitably support specific continuity of care models that enable families to meet their infant feeding goals. But as you're going to see, the availability of community level breastfeeding data, especially data that is stratified by race, ethnicity, and income, is very limited. And through the blueprint meetings, we heard many challenges in accessing local level data. The frustration was even more evident when we divided 2 subgroups, and then the postpartum subgroups like the 3-month milestone and babies over 6 months, because continuation data is almost inexistent by then. So without this local disaggregated data, it's really hard to even state that suboptimal breastfeeding is actually an issue in the community. How we're going to say that there's a problem if there's no data to tell the story? And how is anyone going to show impact of lactation support implementations if there is no data to show increasing rates and decreasing disparities? So next slide, the recommendation 4 states to develop a community-driven database to track infant feeding consistently. Strategy 4.1 talks about assessing existing local data. One of the most known breastfeeding data that is consistently collected in communities is through the local wiki agency. However, we've heard over and over again that this data is not easily accessible by other community agencies. And also, WIC data reflects only a subset of the community. But anyways, other breastfeeding data that is being potentially collected at the local level are those through the home visiting programs like Healthy Start, Nurse Family Partnership, Early Head Start, data from baby cafes, and also probably by some federal qualified health centers and other individual providers, probably through their electronic health record systems. But the type of data collected by each may not align with each other, and usually systems do not talk to each other, which makes it very difficult to safely share data. So this recommendation speaks to the need to improve interoperability across health systems to allow exchange of information effectively. In the next slide, you see we're going to start talking about strategies for this recommendation to establish a streamlined community database. You see that in this recommendation, a lot of the language is borrowed by the collective impact framework and public health informatics. But this recommendation is really the shortest in all the blueprints. And because currently there's not a whole lot of examples, best practices, or useful tools in the field. But we are hopeful that there will be more communities addressing this critical gap in continuity of care. And also, if you are doing some work on this area, please let us know. I'll show briefly some of the few community examples that we know. I know some of them are here in this call today, so please help me out, tell your story in the chat box. But hopefully we can get everybody to come back and present on our recommendation 4 webinar later on this fall. We have Rich recipient in Nebraska. They have been using the collective impact framework, and they use the shared measurement systems concept, which means that partners are consistently collecting data and measuring results. And then the Partnership for Health and Lincoln serves as a backbone organization to manage this data. So they collect and compile different sources of breastfeeding data that includes both of their local hospitals, vital records data for breastfeeding intention, and data from both of their local WIC offices. And they use those to identify trends in breastfeeding duration. They do even more in other program areas where there is an actual standardized indicator. For example, they collect a lot of A1C data, which is an indicator that measures average blood glucose and informs diabetes management. So this data is pulled from their 3 largest safety net clinics in Lincoln. So they have a very good idea on how diabetes control is progressing in their county. And they can tell if diabetes prevention activities are in fact being effective. And then the next example comes from Erie County in New York. This data is a bit old. They plan to develop this county-wide data dashboard and repository to track their county breastfeeding rates. So first, they established the core set of data, of breastfeeding data, and the data format for each partner to collect and report among hospitals, pediatricians, family physicians, WIC offices. So each partner would have the ability to query in real time aggregated rates among all reporting entities. They also wanted to have a storage of data for future research and evaluation purposes. But I've heard they were not yet successful in engaging and encouraging their medical practices to use existing resources within their electronic health records to track rates. But their plan is pretty cool, right? But of course, this idea for a local breastfeeding dashboard did not come overnight, out of the blue, right? This was just one more step within their comprehensive breastfeeding program that you see here next. Here you see that they had previously formally incorporated breastfeeding measures and services into their community health improvement plan. And through that, they had their own strategic plan for breastfeeding and a comprehensive process map for the county, as you see here. So this is to say that data-related activities requires intentional planning to strategically identify what, when, who to collect this data. And then in the next slide, we're going to move on to recommendation 1, and Erie County is the perfect segue because of strategy 1.2 to integrate breastfeeding indicators and goals into community health improvement plans like Erie did. We did the whole 90-minute webinar recently just on that recommendation. So you can see the recording link there. We're going to share in the chat box too. There's a lot of strategies under this recommendation, but today I really just wanted to talk about the data-related strategy 1.1 of conducting a local lactation landscape assessment, which is a little different from the recommendation 4 that I just talked because it involves more than collecting just the quantitative data. So next, for this strategy, I'll share a bit of our Identifying Care Gaps project. So this was a grant project focusing solely on understanding the community. So we funded 8 community partnerships to conduct community lactation assessments. So next, you can see that we based their assessment framework on NACCHO's Mobilizing Action Through Planning and Partnership, or MAP, that has been used for decades to develop community health assessments and improvement plans. So we tailored MAP best practices to include those 3-part assessments. First, you see there community status assessments that quantitatively describe the community, and you see some of the samples of data that could be collected here. The second part is the community partners assessment to understand the individual and collective capacity of partners to address the root causes of breastfeeding inequities by looking critically within their own systems and processes. And finally, third and critical part is the community context assessment to learn through the lens of those with lived experience and dig deeper into historical and structural roots of inequities within the community. And of course, also learn the community strengths, desires, and because we know that the solutions to disparities lies within communities members' wisdom, right? So in the next slide, you're going to see all of our 8 grantees. They all did a great job. I'll just highlight the 4 here with the pictures because of something very unique they shared with us, and we don't have a lot of time. So first here you see the Center for African American Health in the green box. One of their focus was understanding barriers to career advancements for Black lactation support providers and Black families' experience navigating lactation support. So their results show the families experience modern medical racism and very limited opportunities for newly Black lactation support providers across the Denver region. Second, here you see the East St. Louis Health Department. One cool thing that they did was collect data from over 150 local businesses about their breastfeeding friendly practices. And with these results, they know exactly where to focus future efforts, right? Third, we have Coahoma Diaper Bank in the Mississippi Delta. They partnered with the Center for Health Equity and Education and Research, CHEER. So they did a comprehensive assessment of existing community breastfeeding data, and then they found a large data gap in breastfeeding durations and exclusivity. and many difficulties accessing existing breastfeeding data from the state. They also identified other data sources from baby cafes and the CHAMPS hospital initiative, but only CHAMPS gathered data by race and ethnicity, which is crucial for understanding current community disparities and advancing health equity. And finally, here, last, you see the Hmong Breastfeeding Coalition. That, by the way, this coalition was created because of the availability of incredibly disaggregated data that is made available by the Minnesota Department of Health. Through this data, they were able to identify that Hmong families had the lowest breastfeeding rates in many different counties. So they formed the Hmong Breastfeeding Coalition. And through this project, they were able to understand some of their continuity of care gaps and found that Hmong-driven organizations offered no lactation services or referrals, and that most organizations providing lactation support do not offer any culturally responsive services for Hmong families. They also did a very cool culturally attuned community context assessment, which was a video storytelling collection initiative, since the Hmong culture is rooted in oral storytelling to preserve language and traditions. So you can find all their recommendations under recommendation 1 on the Blueprint website. And then next, I just wanted to conclude these examples with a beautiful sample of disaggregated county level data from the Minnesota Department of Health that I just talked about. They do such a great job compiling data from WIC, from birth certificates and hospitals, and make the data very accessible to anyone that requests it. I was very impressed with how much they were able to disaggregate their WIC data by cultural identity. Like you see in this table here, you see Black families from at least 6 cultural identities, instead of lumping all Black infants together as if they were one monolithic group. Very impressive, right? And on the smaller screenshot, you see another graphic of county level breastfeeding data, duration data. So this only reflects WIC participants, but still, I think this is one of the most disaggregated duration that we have seen through the past year, and very accessible. And then just to conclude, I wanted to tell you about the current happenings within the Blueprint. We're currently funding 10 organizations to implement the Blueprint recommendations. And we are also running our Blueprint webinar series. And I would like to invite you all here to the recommendation 3 webinar on May 24. And then in the fall, we hope to bring all these organizations highlighted here today to discuss their project more in depth for webinar on data. So stay tuned. Thank you so much. And thank you, CDC, for all the technical support provided during this webinar. It's my pleasure now to turn it over to Tonya Long and Cindy Young, who have been doing great work in this field. Tonya?
Thank you, Harumi. And thank you so much for the opportunity to present today. Again, I'm Tonya Lang, and I'm one of the co-founders of the collaborative. I identify as Chinese American, and I was born in the US, and I also speak 2 dialects of Chinese. And I'm going to hand it over to Cindy.
Hi, everyone. I'm Cindy Young, and I'm also a co-founder of the collaborative, and I identify as Japanese and Korean American, and I also speak a little bit of Japanese as well. Today, I wanted to go over quickly our overview of what we're going to talk about. We're going to be talking about the diversity of our Asian American, Native Hawaiian, and Pacific Islander communities. We're going to be talking a little bit about the current AANHPI chest and breastfeeding data and limitations. We're going to be talking about the model minority myth and the framing of our data. And finally, we're going to be talking a little bit about the lactation landscape analysis that we're doing within the collaborative. And finally, we're going to be talking about the formation of the collaborative and how we came together.
So let's start by defining our population. What do we mean when we say Asian American, Native Hawaiian, and Pacific Islander? So AANHPI is an umbrella term used to describe many different cultures and distinct languages that represent almost half the globe. The continent of Asia alone has over 48 countries. And the Pacific Islands cover a geographic region that spans a distance broader than the United States and includes dozens of distinct cultures. So with this incredible ethnic diversity comes also a vast number of languages spoken. Let's take a closer look at the Pacific Islands, or Pacifica, which is what I'm told is the preferred term. So Pacifica is further divided into Micronesia, Melanesia, and Polynesia. And here are some of the islands listed within each. I just want to note that the immigration and political status is different for residents of each island, which determines whether one can live or work in the US and access services. And you may even see differences within each family. So where do most AANHPI people live in the United States? California actually has the highest number of people who identify as Asian and the second highest number identifying as Native Hawaiian or Pacific Islander. AANHPIs are a large part of the population in California, and that's why it's so important to understand the needs of our communities. Okay, so let's talk a little bit about data. Dr. Nakayama already discussed the May 2021 CDC MMWR report on racial and ethnic disparities in breastfeeding initiation. And that report found pretty high initiation rates for Asian mothers. In fact, the prevalence of breastfeeding initiation was highest among Asians in 36 states. Nationally, the largest racial ethnic disparity in breastfeeding initiation was 16.7 percentage points. So what that meant was that it was higher for Asian mothers than for Black mothers. And as she mentioned, California did not report its data. And remember, I always said that California is a state where 30% of the US AANHPI population resides, and that's the largest in the nation. So making broad statements about high initiation rates in Asian and Native Hawaiian or other Pacific Islander communities without data from California really misses a large proportion of AANHPIs and their experiences, and doesn't really present a full picture of breastfeeding in our communities. Also, the data in the report only captures any breastfeeding rather than exclusive rates. And again, any breastfeeding can represent as little as one feeding. So just want to put out there that we really need to be careful about how we frame our data. So let's take a closer look at California. So the in-hospital breastfeeding data are taken from the newborn screening program, and the exclusive breastfeeding data at 1 month and 5 or 3 months are taken from the maternal infant health assessment, or MIHA. So data from the newborn screen show high initiation rates for Asians and Pacific Islanders. But when we look at exclusive breastfeeding, we see much lower rates for APIs, which are both of which are lower than the California average. And by 1 month, you see exclusivity drops. The 1 month exclusive rate for Asians and Pacific Islanders is the lowest among all ethnic groups. And the 3 month exclusive rate is the second lowest. So just wanted to note also that the newborn screening data are broken out into Asian and Pacific Islander into two categories. And you see a difference between the Asian and Pacific Islander groups in initiation. But the MIHA data combine Asian and Pacific Islander into one category. So are there differences in duration between Asian and Pacific Islanders that are being masked by aggregated data? We don't really know. Also, MIHA is administered only in English and Spanish. Almost half of those identified as linguistically isolated in California are AANHPI, meaning they self-identify as speaking English less than well. And as we know, language barriers can negatively impact the quality of care in hospital and clinic settings. We're probably missing a significant portion of the AANHPIs in this survey. So let's take a look at my home in Alameda County, which is in the San Francisco Bay Area in California. Here we see high initiation rates and lower rates for initial exclusive breastfeeding. Pacific Islanders have the lowest in-hospital exclusive breastfeeding rates, as you can see. But by 1 month, exclusivity drops to 37% for Asian and Pacific Islanders and continues to decrease at 3 months to 32.7%. Again, the 1 month exclusive breastfeeding rate for Asians and Pacific Islanders is lowest among all ethnic groups, and the 3 month exclusive rate is the second lowest. In Los Angeles County, we see slightly lower initiation rates, but the initial exclusive breastfeeding rate is much lower than what we saw for Alameda County and California overall. Here we see that Asians have the lowest in-hospital exclusivity rates of all groups, and it gets even worse by 1 month. Exclusivity drops to 31.6% for Asians and Pacific Islanders and continues to decrease to 18.2% by 3 months. So Asians and Pacific Islanders have the lowest exclusive breastfeeding rates of all ethnic groups at 1 month and 3 months. And I don't know about you, but I find these numbers to be alarming. And again, why are we focusing so much on supplementation and exclusivity rates? Remember, any breastfeeding can represent as little as one feeding. And while any amount of human milk feeding is of course good and should be celebrated, we know that the greatest health benefits for both mom and baby come from exclusive breast or chest feeding. And that is why it's important to focus not just on initiation rates. So to sum up, AANHPI is an umbrella term used to refer to many heterogeneous groups that differ in culture, language, ancestry, and religion. However, this is not how AANHPIs are necessarily perceived in our country. Asian Americans are often stereotyped as a model minority. So a polite, law-abiding group who's successful due to inborn talent and kind of a pull yourselves up by your bootstraps immigrant mentality. Asians as a group are thought to succeed just as well as whites, but at the same time, Asians are also viewed as perpetual foreigners. However, the myth ignores the diversity of our communities and considers Asian Americans as a monolith that is generally invisible in our society, while also masking racism against our communities. The rampant racism against AANHPIs during the COVID-19 pandemic is just one example. And more recently, on March 16th, we acknowledged the 1-year anniversary of the murders of 8 people, including 8 Asian women massage workers at spas in Metro Atlanta. The model minority myth also completely ignores Pacifica peoples. The perceived success of Asians is often used to divide communities of color, which ultimately harms the goal of achieving racial justice in our community. So from the current data, we see high initiation rates to breastfeed and high intention. We also see high rates of formula supplementation. So why is that? Is that related to racism or unfair or harsh treatment or linguistic isolation? When we look at national data, it appears that we're doing great, but that's not necessarily reflected in the local data. Data for all health indicators are not regularly collected for our communities. And even if we have data for Asians, often data for Pacific Islanders is not available. And we're often told that there are too few numbers. We're too few in numbers to break out the data in its own category. But that's a problem with data collection. It can be solved by things like oversampling of certain populations. Unfortunately, what little data we have on Asian Pacific Islanders are often combined together into one category and do not paint an accurate picture of the health of our communities. The model minority myth combined with the aggregated data paints a much more positive picture of the health and well-being of our communities than what we know is true. And as we saw in the MMWR report, the problematic data, framing of data has implications. Data often drives programmatic priorities and funding opportunities. So what little data we have suggests that our communities are doing well when looking at most health indicators. So that leads to a vicious cycle of fewer allocation of attention and resources to our communities, and then not seeking out more data because there's no apparent need to do so, and then not having the data to show any community needs. And I'm going to hand it over to Cindy.
All right, now I'm going to talk a little bit about some of the work that we've been doing within the collaborative. So we've been doing our lactation landscape analysis, and our landscape analysis began back in June of 2021, and it's the largest AANHPI lactation community needs assessment in the nation. We wanted to really add to the body of knowledge about chest and breastfeeding and human milk feeding in our communities and the resources available, or the lack thereof, to support our communities. So our landscape analysis has been divided into 3 parts. We have our National Resource Mapping Survey, which I'll talk about in a second. We have our Community Context Assessment, which includes a provider survey and a parent survey, and Tonya is going to be talking about that. And then also we really wanted to focus on advocating for disaggregated data. That was a really important piece for us because it illustrates the diversity within the AANHPI umbrella and presents a more accurate picture of chest and breastfeeding within our communities, as Tonya mentioned. Data for all health indicators are not always collected for AANHPI, and furthermore, most data are aggregated under the general Asian American and Pacific Islander umbrella. And so that's the main reason why we wanted to really advocate for disaggregating it. And I also wanted to mention that this project that we were working on as a collaborative was not funded. We all decided that we wanted to do this work and we volunteered to do it. Breastfeed LA, shout out to them. They were able to provide some in-kind support through their staff. And others all volunteered their time for the work that we were doing. So we're really grateful for all of the folks who worked on it. So thank you to the collaborative members who couldn't be here with us today, our extended family. We consider them our family members. So first, let's talk a little bit about the National Resource Mapping Survey. The goal of that was to really create a national list of AANHPI lactation support professionals and educational resources for AANHPI families. And this piece was led by one of our students, Danielle Tropea, and was who developed a landscape assessment tool to gather resources nationwide. We launched the survey back in October of 2021 and kept it open from October to December. And we sought input from lactation support people who either identified as AANHPI or worked with predominantly AANHPI communities. We promoted the survey through many of our partner organizations, including USBC, NACCHO, the California Breastfeeding Coalition, California WIC, National WIC. And so far, we've received 60 responses, which tells us several things, that either there aren't very many resources out there, which we suspect is probably true, or we're just not getting it out to the right people. So we have decided to reopen our survey, and we are continuing to gather resources, and we're hoping that we can further add to the listings and make it as robust as possible. And we plan to share the list when we have a good amount on a website where people can access it for free. And so I want to share with all of you the link here. There's a QR code. So if you'd like to take the survey or know of someone who can and is eligible to take the survey, please share with them. There's also a URL as well that you can share with folks. All right, I'm going to turn it back to Tonya, who's going to talk about the provider survey.
So our community context assessment was led by another student, Sophia Tan, and included a survey and focus group of AANHPI healthcare providers and key informants who serve primarily AANHPI families, and also a survey for AANHPI postpartum parents. So the survey for parents is currently in progress, but for this provider survey and focus group, we partnered with Asian Health Services, which is an FQHC based in Oakland, California. And that's the main site of our community context assessment. So providers and staff at AHS completed a survey and participated in a focus group discussion. Some of the findings that came out from the survey and the focus group is that there was definitely a need for more educational materials in AANHPI languages, more staff training in lactation, and also how to incorporate cultural practices in chest and breastfeeding support, and also a resource directory of lactation support professionals, which we are working on with that national resource mapping survey. And some of the important points that came out of that focus group is that the family in the household, extended family members in the household, have a heavy influence on whether parents will breast or chest feed. We had providers tell us straight out, I can tell immediately who's going to breastfeed depending on how supportive other family members are in the house. They also wanted to know where to access in-language educational materials and needed a defined referral process on where to send patients for more complex lactation support, and also realized that they needed to make some more workflow changes to improve communication. So minor things like the comprehensive perinatal health workers now include their teaching notes in both the parent and the child's chart so that pediatricians actually know what happened and what kind of education the lactating parent received. I'm going to hand it back over to Cindy.
Now I get to talk about how the collaborative formed. So many of you are probably wondering, so how did y'all come together? So it's kind of a nice, very great story I like to share. So the Lactation Collaborative of California, AANHPI Lactation Collaborative, evolved from a joint effort between the Asian Pacific Islander Breastfeeding Task Force of Los Angeles. So that's an organization that I was working with, and the Asian Southeast Asian and Pacific Islander Task Force of Alameda County. And that's an organization that Tonya is affiliated with. And we thought, the North and the South of California, we should all really be working together. And so we decided to write for a grant that NACCHO was offering And it was the conducting communities assessment to improve the chest breastfeeding landscape in historically oppressed communities. And we heard about a lot of the grant recipients. They're really great and much deserving of the funding. We unfortunately didn't get the funding, but we put together a really great work plan that included the landscape analysis and the parent and provider surveys and the disaggregating of the data. And we said, we still want to do this. This is really great work. It's important work. It's not being done. Let's do it. And so we were able, it was just very fortuitous. The group came together. We had some students that needed to do some hours for their master's degree. We had some elders who were in the community who really wanted to give back to the community and had some time and said, you know, we can work on this as well. And we're like, great, let's do this. So we decided to put that work plan to work, and we were able to accomplish a lot of that work plan unfunded. So one of the goals of the collaborative is to create a bridge between mainstream lactation, public health organizations, and the AANHPI community. The collaborative recognizes that many barriers to breast and chest feeding that exist in our AANHPI community, which include limited breast and chest feeding data, lack of culturally humble and language appropriate lactation support, systemic racism in healthcare, and implicit bias among healthcare staff who continue to perpetuate myths such as AANHPI women don't breastfeed. And so we're here to dispel those myths and bring attention and resources to our community who are often left out of important health conversations. And our collaborative really fosters connections between our AANHPI individuals, groups, and organizations who provide lactation education and support. And like I said before, we are really a North and South California statewide partnership that also conducts outreach to other AANHPI groups and to mainstream state and national organizations. One thing that really makes us special is that we really place a high priority on mentoring our AANHPI students and young professionals, including supporting those who wish to become IBCLC. And our collaborative recognizes that there are many additional barriers to building capacity within our communities, and we believe in providing additional support and uplifting our emerging leaders. And so we're always giving them opportunity to lead, to speak at public events, and really put them in the spotlight because we feel that that's important. And another piece that we have included and that we care deeply about is that we incorporate the wisdom of our elders and ensuring that their voice is heard as well. So it's a really great sort of generational organization that encompasses all. The collaborative is also supported by allies from Breastfeed LA and the Alameda County Breastfeeding Coalition. And we've also forged strong partnerships with other community organizations and stakeholders. And that pandemic has really allowed us to form a really close relationship. All these Zoom meetings probably were not a thing until the pandemic. And so that maybe a silver lining that occurred from the pandemic is that we were able to really connect and work together. And we strongly believe that the successes that are, within our collaborative are a result of our strong roots in our AANHPI communities. And our collaborative is also unique in that our efforts are completely organized and driven by our AANH community members with support from our allies within the lactation field. And while one member may take the lead on a specific project, our group norm is to include input from everyone in the group, and we strive to make sure everyone's voice is heard. So we always kind of joke around. We bring our family with us when we do presentations, when we work on different projects, because we feel that everyone's voice is really important. All right. So now you're wondering, what can we do? How can we uplift the AANHPI community? How can we work with AANHPIs? So some of the things that we would call you to do is to look at the data where you are, get to know your communities and who your clients are. And if you don't know, ask questions. Questions are great. Reframing cultural traditions as assets versus something that you need to, work around or work against. Support AANHPI organizations. Include us at the table. Bring in young professionals and include the wisdom of our elders in all conversations. And ensure education provided to the community is culturally congruent, not just regular information that's been translated into another language. It specifically needs to be tailored to the needs of our community. I know we're kind of coming up on time here, so I want to thank all of you for letting us share about the work that we've been doing. And if you have any other questions about the AANHPI Lactation Collaborative of California, you're welcome to reach out to Tonya or myself. Our contact information is listed here. And like I said, thank you so much. And I turn the time back over to Janelle.
Thank you. Thanks for all these wonderful presentations this afternoon. We have just a couple minutes for a few questions and answers. I want to remind our participants as well that the seminar is recorded and will be uploaded on the DNPAO webpage with some links so you can come back to there for some resources. So Jasmine, if I could turn it back to you, we got some good questions about plans for repeating your analysis.
Great. That's a question we get asked very often. We don't have any firm plans, but we would like to repeat something like this in the future. We've received very positive feedback. It sounds like people really like having this data. They would like to have this done in the future to compare trends across time. We would like to include California and Michigan, which means that we would need to wait for the 2021 data, and we also want 2022 data so that we can aggregate the 2 years and have enough of a sample size to look at county level initiation rates.
Thank you. So we're halfway there. Harumi, the next question is for you. The question is, how can we access local WIC breastfeeding disparities data?
Yeah, as I mentioned, local data is usually, any local data is usually fed to state and then probably USDA here on the WIC. So, but we heard that I would start with your state health department, but we heard across the country different levels of accessibility. Some make it very easy to access, and some even I heard one require a fee. So it really depends on your state, but I would start with the state, but then, you know, reach Nebraska, they compile the local WIC data at the local level and they make that accessible too. So I think it really depends on your state and your community.
Thank you. And then Cindy and Tonya, I'll turn a question over to you. Given the diversity of Asian American, Native Hawaiian, and Pacific Islander communities, how does language affect the ability to collect accurate data?
Well, as we had talked about earlier, you know, oftentimes surveys that are done to collect more data aren't necessarily translated into AANHPI languages. At best, we see that, you know, a survey might be translated into Spanish or even a lot of educational materials. You know, that was something that we heard loud and clear from providers who were serving our communities. There just are not enough in-language resources for our families. And it's not a simple thing either, because again, given the diversity of our communities, think about how many languages that represents, you know, even, you know, I'm Chinese, and even for Chinese, there's not really, you know, just Chinese. There's, you know, if you're translating materials, is it in traditional Chinese or simplified Chinese? Or if there's anything that needed to be translated into another spoken language, there are many, many dialects. So that's just for Chinese.
Yeah, so just to add to what Tonya was saying, so we are missing a big portion of our community by limiting the languages that the surveys are offered in. And so that's something that we definitely are, you know, advocating for, is to expand the number of languages that surveys are offered in, so that we can capture more of particularly the folks that are monolingual or, you know, English is not their first language communities. So that's something we're hoping to work on as part of the advocacy work that we're doing.
Thank you. Well, we are coming to the end of our hour today. I really want to thank all our speakers for joining us. We had a great turnout, which I'm so pleased, really showing the interest across the country in how communities can better support breastfeeding. So thank you again to all of our speakers. Thank you to all of our participants for joining us for this first seminar series in 2022. And we look forward to seeing you at the next one. Thank you all.